Anyway, all right. So I'll start. I think this first case is really interesting. I got the first core biopsy when Ben was here rotating a few years ago. So anyway, this is a 75-year-old woman who presented to the ED with shortness of breath, was found to have bilateral pulmonary emboli on chest CT scan. And then they found a large left prevertebral neck mass in the soft tissue that was measuring 5.5 centimeters, abutting C6 and C7 extending into the spinal canal. And so they did a biopsy. So this was actually the second biopsy I got. I'll show you the first one after this. But so this, I don't really know what to say about this other than when I have stuff in this area, I first think, like I've told you guys before, I think about what would happen in that area. The neck is a really scary area because there's so many things that you get in the neck. So then you really just have to kind of go based on morphology and have a huge differential. For this, these cells are like very clustered, lots of intranuclear inclusions, and this pigment. So then the question becomes, what is this pigment? If you have like epithelioid cells with a lot of eosinophilic cytoplasm, intranuclear inclusions, kind of a brownish pigment, I mean, melanoma would be very high in your differential old person. We see a lot of melanomas here, as I went over last time. So that was kind of something that I'm surprised I didn't really think about when I got this first, because there was just something about this growth pattern, the fibrinoid, hyalinized kind of looking stroma, and then these cells that are kind of individual looking, irregular nuclei, kind of bubbly cytoplasm in areas, that I immediately thought this was a chordoma. When I was at Mass General, I saw a lot of chordomas, spine, clivus, so base of skull, and like sacrum are really common areas, but anywhere along the spine, they kind of occur, more so in caudal and distal. But to me, this really looks like a chordoma. So then if you're thinking it's a chordoma, then you have to have a chondrosarcoma in your differential, because those are the two main things. There are other things that can enter the differential based on what you're thinking about, but those are really the two main things that you should really think about. A lot of times chordomas, you have more of a myxoid stroma. This is more hyalinized, and that's why I thought this had kind of undergone degeneration and was hemorrhagic, and that pigment is hemosiderin. And it looks more like hemosiderin. It's kind of, crystalline looking, refractile looking. So let me show you the other core. Well, this was not the other core. This was the other block on this same case. This has more of that lobulated appearance. So that's classic for chordomas to be lobulated. That's an architecture. It's hard to see on core as opposed to an excision, but it's very nested. It looks more cohesive to me than a chondrosarcoma should. Chondrosarcoma, very uniform looking individual cells. When you start getting little nests and kind of trabeculae, that's much more epithelial kind of, these are notochord originating tumors. And so that is more something that you would see with a chordoma versus chondrosarcoma. This is a tumor that's very rare. These are very rare tumors. I'm in a rural practice. We don't see a lot of bone. So this was kind of, I just felt lucky that I've seen a lot of these in my practice before and in training that is kind of has this classic look. The physlipher cells, I don't think are always that prominent. And I think you can look at any tumor and imagine bubbles and call them physlipher cells. So I'm not a huge fan of that. I'm more focus on kind of the nested eosinophilic nature, large cells, low NC ratio, more typical, usually a myxoid stroma. So this was...
The stroma is a bit less prominent here, right?
Yeah, well, yeah, and a lot of it's fibrin. So I think that's what makes it hard, is I think it was kind of a degenerative lesion. And so the stroma isn't, you don't see that typical myxoid stroma. It's just the cells were really prominent, or the cell morphology was very characteristic. So this is S100. You know, most chondrosarcomas should be pretty strongly S100. Chordomas could also be S100 positive. When you have tumors with hemosiderin, you need to be really careful about how you interpret these. You know, immunostains, because you can call something focally positive, which sometimes is all you need to call something positive. But in this case, I did not think that this was actually S100 positive. I thought that most of what was positive were either supporting cells or just hemosiderin. And then here's cytokeratin stain. This was the most helpful of the stains we had in-house. It's off the charts, strongly positive. So then the differential is no longer chondrosarcoma. So to me, I'm like, it's an old lady with pulmonary emboli. Like a lot of times people with adenocarcinomas, you know, Trousseau syndrome present with PEs. So then the question is, well, is this metastatic carcinoma versus a chordoma? I think based on the location, the morphology, to me, this looks much more like a chordoma. I can't rule out metastatic carcinoma. So then that's when you use brachyury. And most labs don't have that. I mean, most private practice labs don't have that in-house. We don't. So I sent it to the Mayo Clinic just as a technical only, meaning, you know, you can do that. And that's why I feel like in a private practice, even a rural practice like my own, I can practice at the same level as any academic hospital. It just takes me longer. So I can do any stain that any of you can do. I just have to wait for it. So I sent the block to the Mayo Clinic, and here's brachyury. So it's a nuclear stain, and it's strongly diffusely positive. So I didn't hedge, I just called it a chordoma. So I just think that this is it's a rare tumor. You don't see these very often. This is not typical as far as the myxoid stroma that you normally see, but the cytology is fairly typical. That nested pattern is fairly typical. This is what I got when Ben was here. And this was the first biopsy where they hardly got anything, but they got this. And he could vouch for me if he was here. But I saw that, and that's all I had in a neck mass in an older woman. And I said, I think this is a chordoma. And it's because this low NC ratio, they're not quite oncocytic. They're much more bubbly than anything. But this was all there was. It was just this little core, this tiny ass little thing, which is, okay, come on. So I'm telling you, I've been having problems. This tiny little thing. Here I'm at 4x, so that's all I had. And most of this was just fibrin. And so we had levels. They cut 2 levels anyway. And this was the second level. Everything was gone except for this. So I can't do anything. So I actually called the radiologist and I said, you need to biopsy this again because I think it's chordoma. So get more tissue because I'm going to have to do stains and send it out. And then it was a chordoma. But it's just based on that tiny little area that really has that classic morphology with the pink cells, bubbly looking cytoplasm. So this is a one that's been excised. This is not, you know, they did not do a chordoma excision at Bay Area Hospital. I don't know where this person went actually, but this is one that I had in residency, and it's a little faded, but you can already make out kind of the lobulated appearance at low power. And then here you can see that more typical myxoid stroma, very vacuolated looking, but pay attention to that because I'm going to show you a chondrosarcoma, and it's not that distinctly different. What is different to me than a chondrosarcoma is that you have clusters of cells, myxoid stroma, clusters of cells, myxoid stroma. Again, these are the phycoliferous cells that are very bubbly looking cytoplasm. When you have poorly differentiated chordomas and dedifferentiated chordomas, which are also other entities. You don't typically see the physlipher cells as much, but here you have kind of clusters of cells, myxoid stroma, clusters of cells, myxoid stroma, and then it can be very corded looking, kind of like the name implies, where you have kind of more of an appearance that it looks like they're growing in little cords, again with myxoid stroma, but it's that kind of cohesive epithelial type of nature that to me is very distinguishable from a chondrosarcoma, which is the main thing in the differential. Here's another chordoma. This one you can see how lobulated it is, multinodular growth pattern. Here, this looks very classic, more cellular along the periphery, very pink, large cells, relatively low NC ratio, almost like renal cell. If you're going to have a differential with a met to the bone, renal cell should be pretty high up there, especially with kind of a clear cytoplasm. Obviously, that would be easy to tell with immunostains, but again, these physlipherous cells, myxoid stroma. But then this one got, and this is interesting, this one again is from Mass General. I don't know that they had poorly differentiated chordomas 25 years ago, or how recently that is put into the differential or as the diagnostic categories, I guess I should say. But you make that diagnosis when you don't have many physlipherous cells. You have a much higher cellularity. You often get more rhabdoid-looking cells, and those lose I and I1. So SMARCB1 is lost. And that's how you tell a poorly differentiated chordoma. Those behave worse, obviously, as the name would imply, which is different than a dedifferentiated chordoma, which, like any other location in the body, usually when you hear dedifferentiated, you see something that looks like a well-differentiated version, and then like ugly sarcoma, ugly malignancy. That's dedifferentiated. Those are even worse. Those metastasize really frequently. These metastasize also, like 30 to 40%, I think, metastasize. They are worse than chondrosarcomas. You need to be able to make this diagnosis and separate them. You know, when I was in residency, we had a guest lecturer from, I think, the Mayo Clinic. I can't remember his name. I think it was Uni or something like that. He didn't believe that chordomas were a thing. So this is not, you know, this is kind of a not a new diagnosis, but this is something that now that's well accepted that these are chordomas. He thought that they were all chondrosarcomas. Or maybe it was vice versa. I didn't. Anyway, I think it was that he didn't believe in chordomas. So this, yeah. So this is a chondrosarcoma. So again, very myxoid stroma. Look at the vacuolation, like that you see. These are all vacuolated looking cells. So I mean, I think anyone could kind of look at that and say, well, that's a physlipherous cell. It depends on how you define it and how specific you're being, but that's why the bubbly nature, the physlipherous cells, to me is something that, yeah, it's a good buzzword. And if you see that on a test, like that's what they're getting at. But to me, it's more the distribution of the cells. I think that chondrosarcomas, as like mesenchymal tumors, are more evenly distributed. You don't see necessarily cohesion, although we'll talk about extracellular myxoid chondrosarcomas in a second that are different. But the typical myxoid bone chondrosarcoma, or just grade 2, grade 1 chondrosarcoma, you have more of an even nature. They can also be very lobulated looking, but have very prominent myxoid stroma. Here's one more. This one, the staining is better. It almost looks like it's in like gyri or elongated groups. Again, very myxoid chondroid looking stroma. Again, these are like malignant chondrocytes basically, but they look pretty bubbly. So I think if you try and use that as a buzzword of like, oh, well, chordomas have physlipherous cells and you got this, you'd say, oh, well, that's a physlipherous cell. That's a physlipherous cell. It's got a myxoid stroma. So you have to do stains, obviously, and these will be S100 positive. They'll be negative for cytokeratin. They'll be negative for brachyury. They actually are less malignant behaving than chordomas. So if you're going to get one, I think you'd want a low-grade chondrosarcoma. And then remember, if this is let's say it's actually a malignant chondroid tumor and you want to call it low grade, in the vertebral body, base of skull, flat bones, those are grade 1 chondrosarcomas. Just like atypical lipomatous tumor is the term used for what looks like a liposarcoma in the extremities. And it's the same with if you have what looks like this, or low grade, like grade 1 chondrosarcoma in the tubular bones, long tubular bones, those are atypical cartilaginous tumors. So they've changed all of that terminology with the most recent WHO. But this was a chondrosarcoma. Again, notice how evenly distributed the cells are. They're not really clustering, forming nests, anything like that. And then let's say, so these are really common in
Paul?
Yeah.
Just looking at differentiating these two, I'm not seeing inclusions in the chondrosarc. Is that a useful pickup to help?
I don't think looking at cytology and chondrosarcomas is useful at all anyway, because so many times they're like pycnotic and maybe you see little nucleoli. The inclusions in the chordoma, I've never really noticed that before. So I don't know if that was kind of an unusual thing in my case, but that's not something that's really described as a differentiating feature. To me, the only thing that was kind of interesting in retrospect, because remember, I was already thinking when I got that biopsy again, I'm like, this is going to be a chordoma. I didn't even think about a melanoma until afterwards. I'm like, hey, this is like large cells, intranuclear inclusions, pigment. Like I should have probably thought about melanoma and I didn't. But I don't think that that's really something good for chondrosarcomas anyway.
Okay, cool.
So again, clivus, skull base is a common location for chordoma. So let's say you have this like skull base looking tumor, and you've got this myxoid looking stroma. The cells have a little more of a higher NC ratio. They don't really look bubbly at all. Maybe you see some inclusions. Look at that. So this kind of looks like a chordoma. This looks pretty bubbly. Look at those nested trabeculae myxoid stroma. That might be an inclusion here. So what's the rest of it look like? Not that. This is looking a little more cellular. So what is this, a poorly differentiated chordoma? The cytology is really bland. And you're in like the skull. So what would you think? Like, what would be your differential? What would you think? What could this be? This could be a chordoma. What if I told you it was attached to the dura?
Meningioma.
Yeah, so there's a chordoid meningioma. And that's what this is. They look a lot like chordomas, but radiologically, they're very different. They're dural-based tumors. These are by definition grade 2. A lot of meningiomas, so you have to grade them. But if you have what you're going to call a chordoid meningioma, which if you see is significant, I don't even know if they have a percentage, but if you see any part that looks like this, you should call it a chordoid meningioma, and it's by definition grade 2. Same with clear cell meningiomas are grade 2. Those are really the only ones that are by definition a particular grade. They used to say that papillary and rhabdoid meningiomas were by definition grade 3, but then I remember I saw tons of meningiomas in Texas because I was at a hospital where we did a bunch of neurosurgery and there were only 2 of us. So I saw like every meningioma, which is at least once a week I'd have one. And I had a lot of rhabdoid looking meningiomas that were really bland, not mitotically active, low Ki67. And that was right around the time they were saying, just because it's rhabdoid doesn't mean that it's grade 3, because grade 3 have really bad prognosis. And so now in the most recent WHO, I think they changed it. So just because it's rhabdoid, just because it's papillary, doesn't mean it corresponds with grade 3. It could be grade 1 to 3. Yeah, this is just basically a type of a meningioma. This would recur more often. Normally with normal meningiomas, if you have brain invasion, that's a grade 2, at least, depending on the other features. If you have over 4 or more mites per 10 high power field, that's a grade 2. And then there's other criteria, sheeting, high NC ratio, nucleoli, necrosis. Those are all things that correspond. If you have like 3 of the 5 with a grade 2 meningioma, so that's how you grade them. You should get Ki-67 anyway because it's over, I think, 4%. Even if it's a grade 1, that has a higher risk of recurring, behave a little more aggressively. Meningiomas are really in the news now because there have been a lot of studies, epidemiologic studies that have come out in the last few years, initially from Europe and now United States, about how Depo-Provera causes a dramatic increase in risk for meningiomas in these women because these are all PR positive tumors. And it makes
Oh
sense.
yeah.
And people are never really, I guess they never really put 2 and 2 together, even though they had all the data. They knew these were PR positive tumors. IHC kind of first started in the 90s. Depo-Provera was been out before then. They never really followed up and said, hey, all these women probably we should be warned of their risk of potential meningioma. So anyway, that's just something that's interesting that's kind of in the news now. So if you hear about that, that's kind of the etiology of it. And then
Will these choroid meningiomas have like any kind of features like like the Samoma bodies or the whirling, or are they just gonna look not at all like meningioma?
yeah, so oftentimes you have areas that look typical.
Okay.
So the hard ones are the ones where you don't see a typical look, but you often have areas that look typical, and you actually don't even think about choroid until you like start seeing other areas that they may be a minority of the tumor. And a lot of the ones I've had, it's been the minority of the tumor. I've still upgraded it to grade 2, even if that's a minority of the tumor.
Okay.
And the WHO doesn't really, I haven't seen that they clarify, like in breast, they say, over 10% of a special type, then it's mixed. They don't really talk about that very much. So I don't know
Yeah.
how neuropathologists usually deal. It doesn't seem very uniform. Now, this is a soft tissue mass, and this is an extraskeletal myxoid chondrosarcoma, which I think can look very much like a chordoma. These are usually, by definition, extraskeletal. These are not in the bone. They often have this cording that kind of looks almost alveolar looking. They're very pretty looking tumors. These are sarcomas, obviously. They really don't have any chondroid matrix like you would expect in a typical chondrosarcoma, but they are very myxoid looking. And they are almost identical histologically to myoepithelial tumors. So myoepithelioma, myoepithelial carcinoma, they usually stain differently and they have different genetics. So for extraskeletal myxoid chondrosarcoma, they're positive for, I think, NA4A3 or something, NR4A3, I think. Whereas myoepithelial tumors are usually EWSR1 mutated. And so this is a case that some of the older residents in here, well, I should say more senior. I've presented this before. This was a case I had here of a groin mass in an older man. And I got this and I saw this area and I was like, well, this looks exactly like an extraskeletal myxoid chondrosarcoma. But something that's become more apparent in the last couple decades, like look at that, that's classic, is that myoepithelial tumors, and this was not something I really learned in residency, but when I've gone to these conferences, they say myoepithelial tumors look identical. So you have to do stains and you have to do the genetics. Once the genetics became apparent, it's kind of standard of care for these tumors to confirm that that's what they are. So this looked like it could be either to me. So I did S100, GFAP, EMA, keratin. It was strongly positive for EMA, GFAP, calponin, negative for everything else. So that really fits with a myoepithelial tumor, but I still sent it for genetics. So let me show you. You guys can see my screen. So this is how I signed it out, because like I said, I had read that these are nearly identical. and that this staining pattern, EMA, S100, Calpone, and GFAP, is almost always just seen in myoepithelial tumors. But I still wanted to send it out for genetics. And so I sent it out for NR4A3 and EWSR, and it came back as they were unable to do it. So then, and you can see this was back in 2021, the end of 2021. So then I signed on an addendum and I said, we're unable to attain it. I tried. You know, I said before that, you know, this is the differential that that these are, the differential would include extracellular myxoid chondrosarcoma as the histologic findings are identical, but the immunostains favor a myoepithelial tumor. Did that, came back negative. I said, it can't, you know, I favor that, but wide excision with clear margins is needed in this case. So then this case, the core biopsy, the patient went to OHSU. And the core biopsy went to OHSU. And with all of this information, you guys just signed it out. The core biopsy is a myoepithelioma. And didn't make any comment about the molecular anything. And I presented this to you guys, and I said, I would not have done this, but this is the differential. It's an interesting case, but you know, they obviously thought it was a myoepithelioma. They signed it out as a myoepithelioma. I would never have done that because of the huge implications of this case. And I really feel like you need genetics these days based on my reading and my understanding. And then not like a couple months ago, I got a request for the slides to go to Stanford, and it was from a law firm. And it turns out that the patient ended up having a recurrence. They did the genetics, and it was positive for NR4A3. So then this is your guys' report. You guys had the resection that you called a myoepithelioma. And so you then called it, you changed the diagnosis to extracellular myxoid chondrosarcoma. And so, and now the patient sounds like they're trying to sue. Well, what happened is after he had a recurrence in his groin, the way it recurred, and because it wasn't being watched because it was assumed it was a benign tumor, he had to have a disarticulation amputation. So this is actually a setup for a good medical legal case, unfortunately. And I think I'm protected because I tried to do my due diligence and do this, and I signed it out descriptively and favored it for a reason, but still said you need to excise it with clear margins. When you give a diagnosis of myoepithelioma, you're calling it a benign tumor, and they're just gonna, you know, shell it out, which is exactly what they did because the margins were negative, or the margins were positive. So the big thing with medical negligence and malpractice is there harm done? If, let's say, if this had metastasized, there may not have been harm done because nothing that we could have changed locally would have changed anything. And so that's part of either negligence or malpractice. The difference between negligence, medical negligence, and medical malpractice is intent. If there is intent, whether it's deliberate or not, to make a mistake, that's worse, and that's medical malpractice and not just negligence. So for that, it's like you should have known better and you didn't. And so unfortunately, I think I helped the lawyers make the case of malpractice because I said, you need molecular in this case because these cases are identical, and I'm not comfortable as a standard of practice. What's the general pathologist? I think most people consider someone working in rural Oregon a general pathologist. And if I felt like that, then I kind of raised that standard for somebody else. So then the real difference is, what was this person's stage? What was their stage? If they were stage 1A or 1B, which he had a 7-centimeter tumor, so that's a T2. And if it's grade 1, then he's a 1B. And that means they wouldn't have done anything, but they needed to have oncologically appropriate margins. And abutting a margin is not an oncologically appropriate margin. So even if this was a grade 1, a 1B, and you don't do anything, you don't give them radiation, you don't give them systemic chemotherapy, it's still a problem. Unfortunately, this guy, I think, because, so he's T2, because it was 7 centimeters. So T2, N0, M1, if it's grade 1, then it's a stage 1B. If it's grade 2 or 3, it goes to stage 3. So then let's figure out what this grade would be. Myxoid chondrosarcomas are by definition tumor differentiation score of 2. This is the French Federation classification, which is what we all use. Almost certainly there would be less than 10 mites. With extraskeletal myxoid chondrosarcomas, these are not mitotically active tumors. So then the distinction is there necrosis or not? On my core, there wasn't, but that's on my core. If there's necrosis, it's grade 2. If there's none, it's grade 1. So then you can see how different it changes. If this was a grade 2 chondrosarcoma, he should have gotten at least radiation therapy and probably systemic therapy also, depending on what the oncologist would have chosen. That's the distinction in the NCCN guidelines. So then I went back to your guys' report, and you don't grade it. When you amended it, you didn't grade it. But when you look at the gross, whoever grossed it said that it appeared 10% necrotic, which goes to my talk about grossing. Don't use these words in grossing, because now if you didn't sample this, the necrotic areas, because some people don't sample like the degenerative looking areas, which you should for specifically in sarcomas for this reason, then if that wasn't sampled, then let's say it was just degenerative and it was just hemorrhagic and it wasn't really necrotic, well, then that's a grade 1, and that might save you from a lawsuit. But now that you're basically calling this a grade 2, you have any lawyer that's going to look at this was going to say this, well, has to be a grade 2. So they had to have gotten radiation therapy. And then if that person got radiation therapy in their groin and they should have had a re-excision because the margins were positive, or a boost with the radiation if they're not going to re-excise it, like, this is a problem case. So again, with gross descriptions, microscopic descriptions, don't make diagnoses. Saying something is necrotic, in my opinion, is a diagnosis, because it's hard to tell necrosis from other things microscopically. I don't care how good you are, just say that it's a yellow, that the tumor is centrally softened and yellow and friable. Say that, because it might not be necrotic, or it might be infarction necrosis, which would not count. So now it's a problem, I think. So I'm honing on this particular point, because you can see this may mean the difference between someone having $1 million lawsuit and getting something dismissed. Although I still think with everything else, this patient has a case. A lot of times we all are going to make mistakes. I make mistakes, but a lot of times your mistakes don't have any consequences. Like I've showed you guys gastric biopsies where I missed a little adenocarcinoma, well-differentiated adenocarcinoma, but then the surgeon was like, on an endoscopy. Surgeon's like, I still think there's a mass. I'm going to go back and biopsy it, because there were tons of fragments and there was a little adenocarcinoma in retrospect that I'm like, oh, I think that was the same tumor because it's really well differentiated. But 3 weeks later, they had another biopsy. A month later, there's no harm done there. A delay in diagnosis of 3 weeks is not going to do anything for a localized tumor. So, you hope that when you're going to make mistakes, there's no clinical consequences. In this case, I think that there was, unfortunately. Anyway, all right. So case 2 is a 53-year-old man had melanoma, intermittent right upper quadrant pain that radiates to his back, so they did a cholecystectomy. And here the question, this is just kind of a chronic cholecystitis. Maybe there's some activity, there's cholesterolosis. But then the real question is, what are these? That looks like it's in a vessel. Maybe. Some of them, maybe you can't tell. There's a ton of them. What are these? Does anybody have an idea? What's your differential?
Yttrium beads.
Very good. What else could be in your differential if you hadn't seen this before and you see purple rounded structures?
I would also think about something like a Sonoma body, or like some kind of microorganism, though that's very low for me on the differential.
Yeah, exactly. I think microorganism is good. Pneumoma bodies is good. Usually there should be some kind of epithelial proliferation around it, although you get metastatic pneumoma bodies in the head and neck for papillary carcinoma, and that's all you see sometimes in nodes. And whether you consider that positive or not has changed over the years. Cryptococcus, it's way too big for Cryptococcus. So Cryptococcus should never be like 20 times the size of a nucleus. And also, usually it's clear. This is kind of has a basophilia to it. So this person had gotten their liver tumor for melanoma had been embolized. And so this is just all the embolic material. In fact, here's the liver, a little bit of the liver that sometimes they get from the bed of the gallbladder. And you can see those same structures in here. I just thought it was a really interesting case. I hadn't seen this in a long time. And just to see so many of them, I think it really kind of, I think the parasite that looks the most like is schistosomiasis. So, and these were in the vessels when you really looked carefully. And so I've shown you this case before too. It's very important. This is kind of like when I talk about these medical legal cases, this is something I also feel like is very important. This is another gallbladder. Always look at the vessels. This is an actual vasculitis. Again, I've shown this to you before. When you have a vasculitis of the gallbladder, it's either a primary single organ vasculitis or it's involvement by a systemic vasculitis. If it's involvement by a systemic vasculitis, these patients usually present with like an acalculous cholecystitis because the inflammation is from the vessels. When it's a single organ vasculitis, a lot of times those patients have stones. Now, sometimes you don't see the activity. This is a very active vasculitis. It's obliterated. A lot of times what you're going to see is evidence that there was a vasculitis and there may not be anymore, where you might just have medial wall thickening. This is an old burnt out vasculitis. It's kind of like endometriosis. Sometimes you see like really small atrophic looking epithelium with like elastotic stroma. That's a burnt out endometriosis. There are a few inflammatory cells here, but this is a vasculitis. So if you get this and that's all you have on your section of the gallbladder, you go back and you do more sections and you look for more activity because there usually is more activity. Here's another vessel that you can see the wall, the endothelium, and then this inflammation. So about 2/3 of the time it's systemic, 1/3 of the time it's single organ. The only way to tell the difference, there's nothing microscopically you can do. The only way to tell the difference is serology and angiography. So angiography, if this is like, a medium vessel vasculitis like polyarteritis nodosa, those are going to be P-ANCA negative. They're often associated with HIV, hepatitis B. They're going to have saccular dilatations on an angiography. Whereas if it's P-ANCA positive, this is not a single organ vasculitis. This is a systemic vasculitis, and that's usually microscopic polyangiitis. The purpose that you need to understand as the pathologist is you diagnose the, vasculitides are very complicated. People use different criteria. Most people now, I think it's a Chapel Hill classification system. And so and I went to a lecture about this at the Palm Springs, USCAP interactive course, and they showed a bunch of these, and they said the bottom line for you as a pathologist is to call this an active small vessel vasculitis, because by definition, the vessels you get in the subserosa wall of the GI tract are small vessels. That doesn't mean the patient has a small vessel vasculitis, because if they have evidence on angiography that bigger vessels are involved, then it's a small and medium vessel vasculitis. Like polyarteritis nodosa is a medium vessel vasculitis. Microscopic polyangiitis is a small vessel vasculitis. And then even patients who have no evidence of systemic vasculitis, when you make this diagnosis as a pathologist, some of them will still go on to have a systemic vasculitis, so they still need to be followed. Now, don't confuse this with a gallbladder vasculitis. So this is a case I just had a few weeks ago after I'd already pulled these cases. And I was like, well, I've got to show this to you guys, because this is a vasculitis, but this person has a necrotizing cholecystitis. So this is a secondary vasculitis. This has no systemic or clinical consequences. And you see this much more often than you're going to see a true vasculitis with the gallbladder. And so, and this, you see this in many organ systems, where if you have a background of like necrotic, gangrenous inflammation, and then some vessels that are within that are inflamed, ignore it. Don't comment on it. Don't make a comment in the diagnosis. Don't talk about it in your microscopic description. Ignore it, because the consequences of clinicians thinking this patient has a vasculitis would be pretty awful. You know, systemic steroids for years, etc. Now, talking about other foreign bodies that get in vessels, this is the lung. And these are the ends of vessels that have this stuff in them. And so it's sometimes hard to tell if you're at a vessel or not, but here you see a pulmonary artery, and that's pretty clear. And then you keep going, and there's more of it. You got to have a granulomatous inflammation around it. So what has this patient been doing? Anybody? No?
Injecting stuff.
Exactly. He's injecting. He or she, sorry, is injecting stuff. So this is basically talc. Usually it's talc. So you can have talc. Talc has more of this plaque-like, I'm polarizing it, has more of this plaque-like appearance. Microcrystalline cellulose, there's probably some of that in there. It's more of like a crystalline, almost like gout looking. And then cornstarch has that Maltese cross look. But most of this is talc, and they used to just call it talc granulomatosis, but basically this is medication filler that gets into the vessels. Even if these patients stop injecting drugs, this can still progress. And they can have more of an interstitial lung disease. They can get future infections from this. So this is what you see basically in IV drug use. And the distinction between this and aspiration is that this is, when you look carefully, it's in the vessels, whereas aspiration would be in the airway. Now, so I showed you another foreign body. This is what the differential, I think, could have been. This is an appendectomy for an acute appendicitis. So now what are these?
Bugs.
Yeah, this is schistosomiasis. So any of the schistosoma can involve the GI tract. I think Mansoni is the most common, but Japonicum hematobium, which is usually in the bladder and causes, squamous cell carcinoma, urothelial carcinoma, all of them can be here. But you look for the terminal spine. I think it's usually hard to tell for hematobium. Mansoni has the lateral spine. Japonicum is pretty rounded, but it has like a knob. I usually don't speciate them on histology. A lot of times they have a lot of eosinophils, but sometimes they're just sclerotic if they're calcified and old. And then now to kind of put it all together, something in the vessel. I tell you about these GI cases, look in the vessels. What's that? That's schistosomiasis, and is a worm in the vein. And that's how they get into the GI tract. So, you go into contaminated water, the larvae penetrate your skin, and then they go to the vessels, and they mate in the veins of the GI tract or liver or wherever. And then the eggs go through the wall, and then that's how they get into the stroma, is they migrate there from the vessels. So always look in the vessels. All right, case 3. Oh, you found the barf emoji. Good for you. All right, 76-year-old woman initially found to have a left adrenal gland nodule 13 years prior, following a CT scan that was done for a fall. So then it was followed, and then it looked like it got bigger, so then they excised it. So this is inside the adrenal gland. Your differential is a few things at this power. Probably more common would be a myelolipoma, to have this much fat. You could have an angiomyolipoma that's fatty predominant. The kidney is not the only place you get them. And then, you know, I guess you could think about other things. So is
Do
this
you wonder
normal?
about well-diff liposarc or ALT when you're actually in the adrenal?
You know, it would be secondarily involve me, but yeah. So
Okay.
I've seen several cases where a kidney mass was biopsied and it was actually a dedifferentiated liposarcoma that had a nodular area within fat, because a lot of, they don't think the fat in the retroperitoneum is neoplastic. So yeah, that could absolutely it would be a well-differentiated liposarcoma
Right.
in the retroperitoneum. But yeah, so this to me is not normal adrenal gland cortex. This is too nested, too big, too diffuse. Look at that. That's not normal fasciculata. And so then, like, well, what's the fat? Adrenal gland or adrenal cortical adenomas commonly have lipomatous metaplasia. But then what's this?
Bone marrow.
Milo.
Yeah, so this is, so then what is it?
Myelolipoma.
So, but what about the adrenal cortex?
Angry. Reactive.
We got a twofer.
So you think, well, you think you have both? You think you have that this is benign, that this is normal, and that all you have is a myelo. Now look at where the fat is. Look at that. That's not normal. That's not normal. There's fat and a little marrow in between it. That's not a normal adrenal gland. And that's not normal adrenal gland, but then what's next to it? That looks like bone marrow, maybe a mega. There were megakaryocytes in here. Oh, here we go. So this is an adrenal cortical adenoma with myelolipomatous metaplasia. It's actually not that uncommon. Adrenal cortical adenomas can have lipomatous and myelolipomatous metaplasia. This is not a collision tumor. It's not a myelolipoma. So myelolipomas have no malignant potential. When they get really big, like over 8 centimeters, they can rupture. So that's the only worry. Usually myelolipomas are solitary, like 5% of the time they're bilateral. But the adrenal cortical adenomas that have myelolipomatous metaplasia and lipomatous metaplasia are more often cortisol producing, interestingly. Now, the one thing I want to focus before I show you the other cases is look at the adrenal cortical cells and how lipidized and microvaculated they are. Make sure you take a mental picture of that and never forget it in your career. Because so often the differential with adrenal gland tumors is a metastatic renal cell, and I don't think renal cells ever look like this. Now, this is just the typical myelolipoma. Here, the adrenal gland is pushed off to the side, so you have normal cortex, normal medulla, and then you've got what looks like, typical bone marrow. Now, you would think, oh, well, maybe you could get like a myeloid sarcoma arising in a myelolipoma, so they should be taken out. It doesn't really, that's not been described. Technically, it could happen, obviously. You have marrow elements and they can become malignant. A lot of times, the problem with myelolipomas is finding the bone marrow elements in the first place, because so many of them are just fatty predominant. And then the differential is, well, is this an angiomyolipoma? Is this really a myelolipoma? When you have a myelolipoma like this is one I had not that long ago. It's like all bone marrow, like cellular bone marrow, nothing that looked really that fatty. So you really can have a differentiation in how much. And then, as I said, a lot of times when you see adrenal glands, sometimes they're in a radical nephrectomy. And this is a case where this is a thyroid. This is a metastatic renal cell carcinoma. So they're always looking, when you have an adrenal gland come out at a radical nephrectomy, if there's a nodule, which these adrenal cortical adenomas are common, and metastatic renal cell to the adrenal gland is not that uncommon. And so one thing that I was always taught in residency that you don't see much in the literature, but every once in a while they talk about glands secreting blood, and that's a terminology I've used with you guys before, where you see clear glands secreting blood is a classic morphology for a renal cell carcinoma, just like this. This is a metastatic one to the thyroid. But then make sure you look at a high power and see, notice how these are clear and like uniloculated. Now, every once in a while, if you go around, you'll find one that looks more microvaculated, like adrenal cortex, but that is like 100% of the cells in adrenal cortical adenoma. Whereas like in this field, you don't really see any that are microvaculated with uniform individual vacuoles. And I just had this case not that long ago. And this is so look at that low power view. What is that? Clear cell renal cell carcinoma. It's got gland secreting blood. This was an adrenal gland nodule in someone that had a clear cell carcinoma. It is not. This is an adrenal cortical adenoma. Look how different these look. And don't go based on the nuclei either, because I think these are more atypical than grade 1 renal cells. So I don't think you can really go by the nuclei. You have to look at the cytoplasm. Obviously, you have to stain it if you're unclear. But no, this whole thing that I was taught that gland secreting blood is classic for a clear cell renal cell, it's not. This is the first case, I think, of adrenal cortical adenoma I've seen that has that same architecture. So if I've said that before to you, I'm sorry. Be careful, because this is a pattern that obviously is not specific to clear cell renal cell. All right, last case. So this is a 22-year-old woman that had a history of a left breast mass for 5 years that appeared to grow significantly over that time. So they did an ultrasound. It was 4.8 centimeter mass. So they did core biopsy. So the question is, I think everyone can see this is a fibroepithelial tumor. The question is how you sign it out, because this is going to be an issue if you sign out breast or general pathology, surgical pathology in any practice, is how you come to a conclusion about how you sign these out. How suspicious are you? How much do you want to like force their hand? What do you tell them? And in general, it's kind of a good discussion topic about what advice do you give? If they ask you, what should I do? Or do you give unsolicited advice and tell them what to do? And this is usually I err towards the former of like not telling them what to do. That's kind of how I was taught. Like I was always given the example, Dr. Young used to talk about a patient who years ago, Dr. Scully had diagnosed with an endometrial adenocarcinoma. It was low grade, and then they did a hysterectomy, and she ended up dying, and they sued, and the surgeon said, well, I only did a hysterectomy because the pathologist told me it was cancer. And so then on all of his like well-differentiated cancers, he used to have like a comment when he would dictate his consult saying, you know, these patients can respond to high dose Provera, et cetera, et cetera. And so he was kind of, swayed by his own history with this. So this to me is a phyllodes tumor. It's way too fragmented to be a benign fibroadenoma. You don't get these kind of frond-like patterns in anything that usually in a fibroadenoma. You know, with fibroadenoma, when you have them excised, sometimes they can look like there is kind of a cystic space, but you should be able, like a puzzle, put it back together. This doesn't look like a puzzle that can be put back together. It has this intracanalicular pattern where the center of the ducts are expanded, as opposed to a lot of fibroadenomas that are pericanalicular, where the stroma grows around it and they're compressed. This has a lot of what? What are all these like vascular looking spaces? This has a ton of PASH. So PASH is something you often see in phyllodes tumors. This also is very heterogeneous looking, like the stroma looks a little more cellular, it's more fibrous with PASH. This area looks very PASH-like, very sclerotic. It's not uniform looking. That's a good sign of a phyllodes tumor as opposed to a fibroadenoma. You know, a lot of times people go and look for mites. I do as well. There are like no mites in this. And so does that mean it's not a phyllodes tumor? No, the architecture is that of a benign phyllodes. So I thought this was a benign phyllodes. tumor, but I never signed it out like that. This is how I signed it out. And the thing that gave me pause also, she's 22. So a lot of 22-year-old women with rapidly growing tumor, it could be a juvenile fibroadenoma. Juvenile is not, it doesn't have to be a young woman. But they can have a lot of overlap. But to me, this was too much like a phyllodes tumor. So I diagnosed it as favor phyllodes tumor. I usually use the term like Phelps, fibroepithelial lesion with cellular stroma. It was presented in a conference not that long ago. I really like that terminology. And then you give the differential. So for this one, the thing that's different for me in practicing Coos County that I've changed is when I have these, and I think it's a benign phyllodes, if you poll most surgeons out there, they all think that any phyllodes tumor needs a 1 centimeter resection margin. This is a 22-year-old woman with a big tumor. She does not need a 1 centimeter resection margin. And so I specifically said, and I almost never do this in my reports, but I said, for most cases of benign phyllodes tumors, widely clear margins is not necessary, as follow-up in these patients is similar to those that underwent marginal breast excision. Like, when is the pathologist there? I never say that with anything else. I do with phyllodes tumors because I've been so often in tumor boards where I hear them talking about how they treat a phyllodes tumor. I'm like, that's not what you're supposed to do. And that has changed into what I'm saying fairly recently, where there have been tons and tons of big studies that have come out from everywhere, from the United States, from Asia, from Europe, all saying if it's a benign phyllodes tumor, they basically do the same with a 1 millimeter margin as they do with a 10 millimeter margin. So don't disfigure these women for a benign phyllodes, for what looks like a benign phyllodes. And then that's even in the NCCN guidelines. So you just do an excisional biopsy, and it says if it's suspicious for benign phyllodes, you do an excisional biopsy. And when you look at what they say, excisional biopsy includes complete mass removal, but without the intent of obtaining surgical margins. And if it ends up being a benign phyllodes, you just follow it up. You don't give them radiation. You don't re-excise. So that's why I specifically do that in phyllodes tumors. I give that little note because so often surgeons are trained to do big margins, and I did not want this young woman to have a disfigured breast because of a report I gave where there was a misunderstanding, which is very common in practice. Now, if something had happened, it's not your fault, but still, I don't want that to be on me. So this was the excision when they excised it marginally. You can see the ink. So they listened to me. And here you have, this is classic benign phyllodes tumor. Lots of these, it used to be called cystosarcoma phyllodes. So this intracanalicular growth, very polypoid looking, some stromal condensation, lots of PASH. Sometimes you'll see squamous metaplasia. That goes good for phyllodes tumor. That other areas, it has more of a pericanalicular. So if you just got this on a core biopsy, you'd probably call that a fibroadenoma. So sometimes there is a sampling issue, but this is clearly a benign phyllodes tumor. So phyllodes tumor, as I said, can be they should more often are heterogeneous. So you see areas that look very different from one area to the next. This is, again, the cystosarcoma, very cystic, very polypoid looking. It looks like a complete mole. And people use that description, kind of knobs like an early complete mole with a myxoid stroma. These look like a complete mole. So these are technically kind of low-grade adenosarcomas because the stroma is kind of malignant. Even in benign phyllodes, the stroma is atypical, usually system atypia, and you usually find mites. So on a core biopsy, if you have really cellular stroma, stromal overgrowth, like more than 3 mites, atypia, those are things that favor a phyllodes tumor. If you have the architecture, if you have invasion, but remember, even in benign phyllodes tumors, they usually do not invade. They're usually very well defined. This is, let's see if this is one. Yeah. So here's another phyllodes tumor. Again, you see how myxoid it is, the growth pattern. It changes histologically from one area to the next. Again, fibroadenomas are usually much more uniform. And breast is kind of, it's not easy. Breast isn't easy, but at least with breast, like if you're dealing with a fibroepithelial lesion, it's kind of, there are only a few tumors you can really deal with. So now this is stromal overgrowth. So I am at 4x and I have a 10x objective, and there's nothing but stroma. That is stromal overgrowth. If you have stromal overgrowth, it is not a benign phyllodes tumor anymore, because the cases that metastasize, most of them have stromal overgrowth on the primary. And so then it becomes, do you call it malignant or not? So then if you call it malignant, it's you've got stromal overgrowth, you've got more than 10 mites, you want to see invasion. If you don't have everything or like a lot, it's very subjective. If you don't have everything, then you call it borderline. But so here, like mitotic activity is going to be really important. And in this case, there were well over 10 mites per 10 high power fields. There were several fields that had like 3 of them in one field. And so this was actually a malignant phyllodes tumor. That's not that malignant looking, but it has stromal overgrowth, very cellular, atypical, lots of mitotic figures. Now, this is easy to call it malignant. This is a phyllodes tumor where there's only a little bit of residual epithelium and cellular stroma, but then it transitions into that, which is malignant looking cartilage, and that, which is malignant looking bone. So if you have sarcoma, like frank sarcoma in a phyllodes tumor, don't do anything else. I don't care if it's well defined. I don't care if you can't find a lot of mites. That is a malignant phyllodes tumor, and it needs to be treated like a malignant phyllodes tumor, because these are very aggressive tumors. Do not undercall these if you can't find other features. If you have malignant heterologous stromal elements, it is a malignant phyllodes tumor. And the reason I'm saying malignant heterologous stroma elements, this is also malignant phyllodes. Very, very atypical, lots of mitotic activity. You can see the epithelium. And then this had this. What does that look like? This is a
ALT.
lipoblast. It looks like a liposarcoma. But if this was all you had, and you don't have the other features of malignancy, you don't have a lot of mitotic figures, you don't have invasion, you don't have really cellular atypical areas, you would only call this borderline. And the reason is because even though this is a malignant stromal component, liposarcoma doesn't, well-differentiated liposarcoma doesn't really have a metastatic potential. And so that's the reasoning for, and you wouldn't call this a benign phyllodes tumor with liposarcomatous metaplasia, because you don't want to use that word liposarcoma. You would call this a borderline phyllodes tumor with lipoblast-like areas. Don't use the word liposarcoma unless you're going to call it malignant. This one happened to be malignant, but then this was one I had where this was a really good borderline phyllodes tumor, where it was very cellular. There were increased mites, but not over 10. It was like 5, like between 5 and 9 is generally borderline. So they were like, I don't know, I think they were like actually more like 7 or something in this case. It's very well defined. It was not infiltrating, and it had very focal lipoblast-like areas. And so this is an example where you have what looks like liposarcoma, and it's not a malignant phyllodes, so it's not definitional. All right, last case just to show you in comparison. With a young woman, rapidly growing tumor, you have to think of a juvenile fibroadenoma. They more often have that pericanalicular growth pattern. When you start seeing these open up, then you start thinking about phyllodes tumors. But when it's very compressed, you should be hard-pressed to call a phyllodes tumor. It's probably not. You can have mitotic figures. Usually they say under 2. I had one that looked very similar to this. There were some intracanalicular areas, and I found like 5 mites. I was really, and it was like an 18-year-old woman. This was several years ago. I sent it to Stuart Schnitt when he was at Beth Israel. Now he's at the Brigham. And he said, don't worry about mites with these. This is a juvenile fibroadenoma based on the architecture. It was very uniform like this. So that was kind of a good lesson for me. I don't focus so much on mites anymore with these. I don't get worried if something looks like a juvenile fibroadenoma. See how uniform this is in comparison to a phyllodes tumor? So a very pericanalicular, compressed, ductal structures. So again, the word juvenile does not mean they're all young. It's based on the overall very myxoid, condensed appearance around the epithelium. They often have more mitotic figures than just the regular fibroadenomas. And it can grow really fast. Once they're over 5 centimeters, you call them giant fibroadenomas. Doesn't really change anything. All right, that's it. So my next one is not going to be until December, and I'm going to be in person. I'm going to be on my way to Leavenworth, Washington, for the Christmas lights. And so I'm going to stop with you guys and do this in person. So I'll probably have a little more subtle cytology cases because I think it's better when you can look under the microscope. Okay, any questions? Max, any questions?
I think I got mine along the way. Thank you,
All right,
though.
good.
Thank you for the spooky cases.
Yeah,
Yeah.
scary.
The extraskeletal myxoid chondrosarcoma, that's a very scary case. And, with these cases, you always hope that maybe the patient ends up not suing. I feel like there's a lot of cases where I've made a mistake and I thought, boy, if this patient knows to sue, I think I could be screwed. I know this patient is thinking about suing because an attorney is involved and the case got sent to Stanford. My case got sent to Stanford and your case got sent to Stanford. That's why they overturned it. I didn't overturn mine. There's nothing to overturn. It was a core biopsy. I gave the differential. I favored one for very good reason. The immunostains were completely supportive of that. So I think it's going to really, depend on what happens, how the pathologists have a lot of sway with these cases. I have seen as an expert witness several cases where a bad mistake was made, but I felt like it was a reasonable mistake. Like I don't know if I've told you this, there was a case where there was a pathologist who had missed an undifferentiated nasopharyngeal carcinoma on a small oral biopsy. And it was there, but it was at the base of the biopsy. It was in lymphoid stroma, which they usually are, and they looked like they could have been like centroblasts, but they were obviously, in retrospect, malignant epithelium. And this was when I was in Vegas, and she was also a Vegas pathologist with the other group. And a local firm asked me to get involved. They said, it's not your group. And I looked at the biopsy, and she actually, in the microscopic description, we all did microscopic descriptions in Vegas, which I hated. That was my first practice. I'm like, what are you doing microscopic descriptions for gallbladders for? It's such a waste of time. But then my group in Austin did the same thing. It's so fucking stupid to do microscopic descriptions. Anyway, it's more of a marketing thing, but she did in this case, it helped her out because she talked about at the base, there was a reactive germinal center. So in my opinion, as the pathologist being consulted to whether this is like negligence or malpractice, in my opinion, I said, this is a known pitfall. She saw it and she interpreted it incorrectly with a differential that is the known differential in this case. And it was a very subtle case. So I told them, I'm not going to be the pathologist. If you're going to sue her, you have to find another pathologist because I will not testify against her. I think this is a reasonable mistake to have made. And I've said that several times. I'm not just a pathologist defender. There have been other cases where I've seen a pathologist make a mistake and I'm like, yeah, they need to be sued. That was an awful mistake. It was, negligent. They were obviously rushing. They weren't paying attention. Like, not all doctors are good doctors, and bad doctors, there need to be consequences for bad doctors. So anyway, yeah, I don't know what the Stanford pathologist said, because he may have looked at everything and looked at mine, because mine was not subtle, and I don't have the stains anymore because it's a legal case. But I am telling you, my EMA, GFAP, and calponin were off the charts positive. And so that should not be an extraskeletal myxoid chondrosarcoma. But I still, because I knew of this differential and how similar they are, and I always have a baseline distrust of immunostains. I still wanted the molecular testing, but this pathologist may look at the case and say, you know what, this was a reasonable mistake. I don't think you've got a case. So we'll see what happens. Anyway. All right, I'll see you guys next time.
Oh, I got a quick
See you in
question.
December, man.
All right, bye.
All right.